interrupt anytime if there's any issues with slides advancing. Thank you for that introduction, Julia, and for this opportunity to chat with everyone here. As Julia mentioned, I work in the ICU at SickKids with Katie, who is our RT educator extraordinaire, and we thought this might be a good opportunity to review. Ultimately, initially at the request of Arif and from South Lake, to have a chance to reflect on the management of children presenting to the community with bronchiolitis, with asthma, with pneumonia that's progressing to ARDS, and discuss that management, which starts to move into the domain of critical care. What happens, or how can we work together to manage patients who are looking to move to our ICU. This picture is some very cheerful bloodletting going on here, just to say that our management today of these three conditions in particular, I think there's still much to be learned, and then of course some of that learning is ongoing in this current surge. So thank you for all of your patience, and I know it's been an incredibly difficult, I would say, month, but I feel like it's been really more like 2 months of very high uptick in volume. So what we're looking to do is review the medical approach to asthma, bronchiolitis, and ARDS as much as it pertains to children who are progressing towards more acute critical care needs. Katie is going to take over after I speak and focus on a number of tips and tricks and indications, and then how to troubleshoot non-invasive ventilation in particular, together with some tips around heated high flow use as well. And even some early management if patients are needing to move on to a ventilator. And then we'd like to leave a good amount of time at the end for Q&A. For context for today's discussion, and this will, if anyone's watching this after the fact, just pay attention to the dates here, because this is from yesterday from CCSO Critical Care Services, just highlighting, if you look at the bottom, the baseline number of critical care beds is in principle 112, and the census was 114. That's yesterday. So we might not be, as much above 100% as we were a few days ago, but we are still above 100% occupancy, which is never a great situation to be in. Another point for more local context too is just to highlight what we're seeing, what's driving, all of these conditions, the bronchiolitis, asthma in older kids, and ARDS or pneumonia in older kids and teenagers. And really, as you can see, the blue bars represent the number basically of NP swabs that are tested. And that really reflects the number of children who are admitted, given that they're the ones who are typically getting these swabs done. So you can see, as we've moved from early September into early November, there's been a steady uptick in the number of tests, again, a surrogate for admissions. And the percent positivity is extremely high now for influenza in particular. That's this gray line here, where you're seeing 90 positive tests out of just over 300 tests that are being done, so close to 25% positivity. And RSV remains high, close to 20% positivity, and below that is rhinovirus, which has fallen a bit from 25 to 15% positivity. So still a number of viruses out there, of course, but the predominant admissions that we're seeing are positive for RSV and influenza. On a provincial level, and again, I don't know that this is true as yet more locally, and this is available, it's the KFLA public health site that hosts this data, but it's province-wide. And just to say, there may be some glimmer of light at the end of the tunnel, in that if you look at the admissions data for children aged 5 to 17, we may be moving a bit past the peak, and perhaps starting to plateau, at least for the children 0 to 4. Bearing in mind that even at a plateau state, we're above this red dotted line, which is the 2 standard deviations above historic average mark. So we're certainly still in territory that is uncharted and very high volumes. And ultimately, this just summarizing much of what I'm saying, I would add that, some wrinkles to this include a lot of co-infections. So some of the children coming to us with influenza or RSV or parainfluenza are also positive for Staph aureus, for strep pneumo in their blood, and that's complicated many of their presentations. I've mentioned PICU occupancy, and I think the impetus for discussions such as this one is just reflecting that it is prudent to review and to stock equipment that may be helpful in temporizing the care of those children for whom we don't have immediate availability, for example, of a transport team to retrieve that child, and perhaps to review and adopt equipment changes that might simplify some of the immediate stabilization. And I think a number of community sites are now, for example, using ARDS device to assist in some of acute asthma management. And what I would emphasize, though, as the baseline, for this talk here, is that we're not asking or planning to ask that any community sites admit children with non-invasive ventilation needs, right? And one exception would be those neonates who are presenting to sites for whom neonatal non-invasive use is within their scope. But apart from that, this talk is not meant to provide a guide to admit children on non-invasive support or invasive support, but rather to provide a bit of advice, perhaps in advance of those cases where there might be delays based on geography or availability of transport assistance. So moving forward, then, the first thing I wanted to cover was bronchiolitis. There's a million of these graphics available online, and you all know this much better than I do even. But to emphasize that, the pathophysiology that we see in bronchiolitis, of course, is that, airway inflammation, mucus production, and air trapping, wandering atelectasis, and this is typical in infants who are presenting to our care. What I would emphasize here, I suppose, when it comes to the cases that we end up discussing on the bridge line, is a few adjuncts that can be helpful in preventing that baby's situation from worsening, and perhaps helping even to avoid transport or the need for non-invasive ventilation. One is deep suctioning, and I know that Katie will have some more advice related to this if anyone would like. But another word for this, or a proper word for this, would be nasopharyngeal suctioning. So, using a well-lubricated suction catheter, advancing it, you can measure beforehand, but trying to advance it down to the posterior pharynx and suction up, that mucus that isn't being cleared out of that area by the baby. And I put a little reference here, and I'm certainly happy to share these slides after as well. One of many sites that has some nice guidelines around and just an approach to that deep suctioning, and that's something that can go a long way to help in babies who aren't able to clear that for themselves. Katie will also have a bit of time in her presentation to review some of the troubleshooting around heated high flow nasal cannula, and one is attention to prong sizing, making sure that the prongs are rated to deliver the flow that you intend to. And not to, I feel like in the past, we were, 0.5, 1.5 liters per kilo per minute. And I think right now, seeing it more as a yes or no solution, so trying at 2 liters per kilo per minute, realizing that if that's not working, there isn't much merit in going much above that. And, so no point kind of going to 3, 4, 5 liters per kilo per minute, because if you're delivering or feeling like you need to deliver that much flow to support work of breathing, then I think it's time for CPAP. And of course, if the baby looks incredibly well on 2, then sure, there may be room to dial that down in the short term. And moving to non-invasive ventilation in the presence of persistent work of breathing, of course, and babies with bronchiolitis. I mean, one of the typical next step in escalation there, which would be different, for example, from severe ARDS or asthma, is often CPAP, and grunting is often one of the first indications that that's a therapy that's going to be helpful. Of course, significant retractions, in spite of efforts to clear their passages, to apply high flow, and seeing nasal flaring tracheal tug. All of these, of course, are pointing to a work of breathing that isn't being supported up to that point, and would be a reason to invoke non-invasive ventilation. And remembering too that, yes, there's of course a wealth of guidelines relating to bronchiolitis management. And I think we're the first ones to put those aside sometimes when we have children who are peri-intubation, and you'll see us invoking therapies, Ventolin, hypertonic saline nebulizations, and so forth. even though, of course, those would not be standard at all on the ward. So those are just some things to pull in, perhaps as a last resort, in those patients for whom we feel there may be a basis for that individual, that there's perhaps a degree of wheezing here, or a degree of mucus that isn't being cleared that might be helped by some of those therapies. And one word to the wise there, because again, we're going to talk a bit about aerogen device and heated high flow. One danger of how easy the aerogen makes nebulizations is just that you need to remember to reassess, and if those nebulizations aren't helping, then to turn them off, because it makes it easy to turn those things on, and maybe a little harder to remember to turn those off when they're not working. Indications for intubation, I think this isn't going to be new for anyone, of course, but when you're seeing that work of breathing persist or worsen even in spite of efforts to use non-invasive ventilation, and if you're seeing hypoxia that's refractory to those interventions, or rising hypercarbia and acidosis on their gas, importantly, and especially in younger infants, the presence of apneas that aren't responding to any of these therapies, or that are worsening or becoming prolonged, these would all be reasons to move forward with intubation. Katie will look at a few considerations around non-invasive use and mechanical ventilation settings in some of these patients. So given the age typical of those presenting with bronchiolitis, they're breathing very rapidly. Synchronization can sometimes be a problem with efforts at BiPAP. So another reason that CPAP can be a great first place to start. And then I think we'll be talking through some basic, ventilator settings, and those are going to be, or starting points for a ventilator, and those will be especially relevant to this population, and less pertinent to those with ARDS or asthma who require sort of much more kind of customized fiddling for their ventilator support. But again, I can't emphasize enough that if you're moving to a point where you feel like this child needs CPAP or BiPAP, or needs to be intubated, and we need to manage or support that child before the team arrives, we are certainly at the very least available for advice and guidance around all of that over the phone. And so, I think this discussion is a good chance to engage with these therapies, but I don't feel that we're asking you to memorize all this in the moment, or that we won't be available to help troubleshoot all these things in real time. So moving forward to asthma, just a reminder of some of the pathophysiology here, right? So when, for someone who's healthy and not having an asthma exacerbation, their alveolar pressure, their end expiratory pressure might be 5 centimeters of water. And so you don't need to generate much negative pressure to move air into that alveoli, right? So generating pleural pressure of -6 will create a pressure gradient between your alveoli and the outside world, and you can move air in, breathe in without very much effort. In the case of asthma, you have this gas trapping phenomenon. You have analogous to what we see in bronchiolitis. You have a degree of airway inflammation that is obstructive to exhalation. So you have a buildup of air within alveolar spaces that leads to a positive intrathoracic pressure. As you can imagine, if your resting alveolar pressure is no longer 5, but rather 15, to generate a negative pressure gradient to move air into that space, you have to generate a negative pleural pressure of -16, for the purposes of this diagram. And that takes work, because instead of just a normal resting, inspiratory work, you suddenly have to take a big negative breath effort to pull air in against a gradient that would otherwise be positive, because you have this air gas trapping within your alveoli. So this is where there can be a role for non-invasive ventilation as an adjunct that can help support that work of breathing. And I think even not that long ago, there was a lot of reluctance in using non-invasive ventilation in children with asthma exacerbations. And I think part of that was that, would this be a device that's going to perhaps bring a higher risk of pneumothorax, or sort of drive further air in, or promote further gas trapping? But over the years, I think we've developed a lot more familiarity with the use of non-invasive in this context. And certainly, it can be a great way to address work of breathing while you're waiting for your acute asthma medical therapies to work. There are, of course, higher risks of air leak than not being on non-invasive, but to the extent that it can offset work of breathing and prevent a child from tiring out and needing intubation, it's certainly the lesser of those two evils. It is a device, non-invasive ventilation is something that typically will require the need for a good amount of sedation, especially in younger children, especially when they're wired on a lot of Ventolin as well. So we'll talk about that a bit later in this presentation. There's a great, CPS has a great resource for managing acute asthma exacerbation it's only from last year. I would just emphasize a few things, making sure that when you're giving mag sulf that you give as much as possible something close to maximum dose, starting with 50 milligram per kilo. And you can give it in 25 milligram per kilo increments, but giving more if it's something that's worked. Starting steroids early and moving to IV methylpred Q6 when appropriate. We do favor nebulizing Ventolin in children who are, if they're more hypercarbic and less responsive, and they're not going to be able to cooperate as well, for example, with MDI, or if they're extremely tight, quiet, and you're unsure how effectively they're going to be drawing in what you're trying to deliver through MDI, I would move quickly to nebs. And I also wouldn't put too much stock in the kind of age-based dosing, I suppose, when it comes to the Ventolin dose, because I know there's an age where you might give 2.5 milligrams rather than 5. For me, and I think for my colleagues, we see Ventolin as something that you ultimately are trying to titrate to effect. And so would certainly err on the side of giving more if you feel like it's not working well enough. If you're giving 2.5 milligrams and the child's not even tachycardic and they're still very, very quiet, just give more, give that 5 milligram nebulization. With the Aerogen, it's easier to dial in like an hourly amount. And we would run in that device up to 20 milligrams. That should read 20 milligrams per hour. As a continuous infusion, not per kilo, just 20 milligrams absolute dose per hour. And that's something that, again, you can titrate as needed to what the child is doing clinically. Beyond that is IV Ventolin, where our starting dose is 1 microgram per kilo per minute. And that can be escalated, every 10 minutes or so. Remembering that, at least according to the medication labeling, for teenagers, they consider a maximum dose of 20 micrograms per minute as an absolute dose. So in older children, keeping an eye on the toxicity that can develop, you'll see patients on IV Ventolin becoming, tachycardic, often impressively so, jittery, sometimes nauseated, with sometimes a lactate that can start to evolve in their blood work. So those are indications that we would use to at least, avoid further escalation or hold off on that as much as possible. Another adjunct is aminophylline, which we still give and give more than you might think, because I know it's historically been seen as a bit of a more dangerous drug, as it were, given it has a more narrow therapeutic window than Ventolin, for example. But it can be quite effective, and certainly if IV Ventolin isn't doing what you need it to do, then we move forward with and use aminophylline. Other adjuncts that are going to be very much an ICU or operative setting would be inhaled anesthetics, and those, the delivery of those, of course, requires an advanced airway. Prior to that, heated high flow can be helpful, and as mentioned, non-invasive ventilation can help support any child whose work of breathing is starting to worsen. A couple of questions, from Kevin: how fast can you escalate the IV Ventolin? Honestly, I don't think I would do it faster than every 10 minutes, but certainly you can do it every 10 minutes. I think just giving it that time to re-equilibrate and see if you're seeing a difference there. And I agree that aminophylline is not used in the community much. I think there are, of course, risks, with aminophylline, as with Ventolin too, but perhaps to a lesser extent in terms of provoking, tachyarrhythmias, for example. And I think if you have time, if you have a child who's stable, sick on non-invasive, but they're holding their own, then I agree that's an intervention that can certainly wait for an ICU setting. The further you are from an ICU, we might be counseling its use in the community, but we do try not to use. Certainly, it can be given outside of an ICU setting. It's something that can certainly understand that if it's a preference that you wait for the transport team to be there, then that can always be done as well. Yeah, no, I hear you, Kevin. So there's different practices with IV Ventolin, right? And I think there's some will use a load. I personally, like to Joe's question, I don't load Ventolin just because I feel like we're often starting it after already providing a decent amount of continuous, nebs of Ventolin, for example. The child is already, tachycardic to 170, 180, and I think we see IV Ventolin work, and I feel like when you're starting it and you up titrating it, you'll get to that point where it's going to be effective. I don't think I would start at 10 personally, Kevin. I mean, I don't do that just because, again, I'm usually starting it in children that I've already been putting on a lot of continuous Ventolin. So I want to make sure I don't drive the heart rate immediately from 170 to 220, but we certainly will escalate it up to that level, relatively quickly, and even higher than 10 per kilo per minute. But looking for an opportunity to dial it down when we can. Roxana, I don't have the dose of aminophylline on hand here, but I can look that up for you after. Claudia, you have a hand up too. I don't know if you wanted to jump in. Claudia, I don't know if you're speaking, you're on mute. Okay, we'll just move forward to the next slide for now, Claudia. But if you put your question in the chat, or when I'm done the slides, we'll certainly have a chance for everyone to ask questions verbally too. A few words about intubation and asthma, but the most important words are to. Whoops, I think I just pause my share. There we go. The most important words is to avoid intubating asthmatic patients. Maybe before I chat about intubation in this context, to address a couple other points in the chat. Ipratropium, yes, Mohammed is certainly still using that and giving that, again, in nebulization form if possible, acutely together with the IV Ventolin, with the nebulized Ventolin. IV and IM epinephrine is also an option. I think that would reserve for more cases that may be presenting perhaps in more extremis, where again, like an IM epinephrine dose can be of use. And Allison, the role of ketamine. So, I mean, ketamine does have some bronchodilatory properties. Generally don't give it as strictly as a bronchodilator. I think if you are looking for sedation or an intubation medication in a child with bronchospasm, ketamine can be a 2-for-1 kind of medication in that case. But generally not giving it acutely as something to address the bronchospasm per se. Sorry, I keep pausing my screen share here. So the issue with intubation in asthmatic patients is that it is a very high risk of cardiac arrest for a few reasons. One is that you have a pre-existent situation of a very high positive intrathoracic pressure, and it's made even more positive when you move that patient who is breathing with a negative pressure effort, and you change that to you taking over and delivering positive pressure ventilation. So at the same time as you do that, you also take away that patient's ability to use their own work to actively exhale as well. And so you can quickly drive a baseline high intrathoracic pressure much higher and really drop preload to an important extent. So venous return really dropping off and really putting a great strain in terms of RV afterload as well. And these are patients too who are typically presenting with an important degree of volume depletion too. So it kind of makes that bad situation worse and very, very high risk of cardiac arrest. And so this would be a situation where you would certainly call a friend, and that includes us on the bridge line, but also any local supports as well. And like Allison had highlighted, ketamine can be a great adjunct in terms of whatever meds you're bringing into bear here. Ketamine, propofol, are both medications that will help address continued bronchospasm as well. But you'll be looking to achieve RSI with an experienced operator, and may need help to actively assist exhalation. So kind of giving that patient sort of a gentle but firm sort of hug to assist in exhaling a lot of the air that gets trapped in this process. And again, this is not something that we need to talk through in detail, because this is something we would be actively supporting online on the bridge, but you'll be looking to set a very low rate on the ventilator to allow for exhalation, watching carefully for air trapping for that flow to not return to baseline. And the goal in the context of a patient who's become so obtunded and acidotic that you need to intubate becomes hypoxia rather than hypercarbia. So and I will say, as much as a rising CO2 might be an ominous sign in an asthmatic patient, and there isn't a CO2 at which you must intubate, right? So we have patients with CO2s that hit close to 100, including some recently, because it feels like in some of the 4 or 5-year-olds who may be getting RSV for the first time, some have come in with quite severe asthma exacerbations. And I think there was one recently with CO2s that were approaching 100. And there we've been able to manage them without intubating, right? Just giving them time for all of these therapies to come into effect, and supporting with BiPAP is something that can offset the work of breathing in this context, right? So, really, really rare that anyone should need intubation for asthma, and a really, really high risk situation that hopefully can be avoided with invoking all of the acute medical therapies. And wanted to talk then about ARDS. And again, like this is a pathophysiology which is occurring in patients who are destined for ICU care. And this is a reference just to that highlights some of the definitions that we use for ARDS, that are all, of course, overly complicated, but we use the oxygenation index in children to describe mild, moderate, or severe ARDS. And that's a function of a few things, but importantly includes the mean airway pressure as a variable here. In contrast, on the adult side, the Berlin criteria classifies mild, moderate, and severe based on the PF ratio, so the ratio of the arterial oxygen to FiO2. And we got a bit more fluent with that, even when we had adults in our ICU last year with COVID. And I think with older kids and teens, we'll kind of default to this still. So what may be worth highlighting, if I go back one slide, is that if you see in the oxygenation row here, there's a kind of shout out to non-invasive mechanical ventilation, where they invoke something called the SF ratio. I would say, even though that's here in this table, and yes, you can have patients who could by definition have ARDS based on what you're measuring from their saturation and their FiO2 on CPAP or BiPAP. We don't in practice use the SF ratio, but I think it's helpful to point this out just to say that you don't have to be intubated to have ARDS. And I know many of you have seen, and there have been a lot of very bad influenza cases over the past few weeks, ARDS that's presenting, that can be managed temporarily with non-invasive support, but which does continue to progress rapidly and ultimately needs intubation. And the underlying pathophysiology there, you're seeing an airspace disease, right? So a destructive, damaging process in the alveoli with capillary leak, with this pulmonary edema, with inflammatory exudates that come into play. And these are patients that really struggle with, present with an impressive work of breathing, tachypnea, grunting. And for them, compared to, a child with bronchiolitis, for example, they're going to need a very high EPAP or CPAP, that expiratory pressure setting. And will often need high pressures, and what you'll generally see in these cases is that, even on non-invasive ventilation, you continue to have a degree of work of breathing. And we've had some based on proximity to our ICU, for example, where we've, I think, appropriately temporized with non-invasive ventilation, and as long as those children have, good oxygenation and their work of breathing allows some time, but they all end up needing intubation ultimately. And this too is a high risk situation. I mean, every intubation is high risk, of course, but some of the things that are working against patients in this context include a degree of hypoxia, right, which can certainly impact your contractility. Volume depletion is often true in these patients as well. They're dehydrated, they have very high insensible losses, and just feel unwell with poor PO intake, usually for some days prior. And again, you're moving a patient who's breathing with negative inspiration into a situation where you're trying to deliver positive pressure. And it's easy to underappreciate just how much negative pressure some patients generate, and can be very difficult to match that on the positive pressure ventilation mode, on the ventilator or with bagging the patient. And the positive pressure that you need to apply often, again, will limit your venous return, limit your preload, and further stress your right ventricle. So these are situations, as with any intubation, and with any high-risk intubation in particular, where it's important to have a good timeout, pre-brief. We use in our ICU setting something we call pre-arrest epinephrine, where we dilute arrest epinephrine, which is 1 in 10,000, to 1 in 100,000, and give 0.1 ml per kilogram doses at a time. Perhaps more importantly than that is to make sure that volume is on hand to address any hypotension that evolves during this, to carefully assign roles and responsibilities during that intubation, and to reflect on the medications that you're going to use there, using medications that will perhaps better respect the hemodynamics, right? So avoiding benzodiazepines, using fentanyl, using ketamine instead. Other strategies that we'll use include prone positioning and inhaled nitric oxide. Both of those strategies can certainly be something that ACTS helps with. We can bring nitric on transport, and we've transported even some children prone. And we cannot give high frequency ventilation on transport. We don't have a device that travels as yet that can deliver that, but it's something we can start here. And of course, ECMO is the last resort here if needed. To briefly review, and I want to make sure that Katie has a good amount of time to speak too, so I'll move through this last bit relatively quickly, but just that there are, some adjunctive investigations that can help guide which direction you're taking patients in, right? So of course, there's a sort of classic and themes to X-rays in these contexts, right? So if you have that middle X-ray, that hyperinflated X-ray of an asthmatic, that can bring some confidence to continuing to pursue those therapies in patients. Like I would say that what we're seeing, with RSV asthma, with parainfluenza asthma, with human metapneumovirus, we're seeing many viruses provoke an asthma phenotype that can be, a bit outside of the textbook, right? And so I think just making sure that you're confident in the pathway that you're heading down, right? And I think this middle X-ray would give me confidence in continuing steroids and continuing nebulizations, depending on what I'm seeing clinically. And on the right-hand side, just that ominous ARDS picture, with bilateral opacities that are evolving rapidly. And those are patients in whom, that you need to move them out and close to an ICU or to an ICU as soon as possible. And then just a word for investigations. That gas is often the mainstay and something that we'll ask for on the bridge. Arterial ideal, but capillary and venous are certainly quite helpful. And I think here it's something that can help guiding decision-making around escalation of support as well. Some children present with a degree of underlying complexity, and their baseline sensorium might mask a degree of hypercarbia that isn't so clear clinically, right? So a gas can be helpful there, of course. And then otherwise too, trying to distinguish, does this child need CPAP to address hypoxia and work of breathing, or do they need BiPAP to address hypercarbia and work of breathing? So sometimes it can be helpful to make that distinction. And close attention with the gases you draw to lactate, to bicarbonate. We've seen, of course, metabolic disease and DKA, septic shock, myocarditis, especially with influenza circulating. We've seen some severe myocarditis. All of these can masquerade as pneumonia because they can have children presenting with that respiratory compensation for acidosis, where they seem, well, they are tachypneic, but the reason for that is because of the metabolic acidosis. But of course, these can also simply coexist with viral pneumonia as well, and you can have a mixed picture. I would add, just as for bonus points, if you have, especially the ability to do rapid viral swabs, that can be very helpful for us just to cohort these patients too when they arrive, as we do tend to give to put patients together in the same room if they have some of the same viruses on hand. Okay, just going to the chat briefly before we move ahead to the last section here. Roxana is asking about propofol, and certainly yes, propofol can reduce blood pressure further, and has to be used with caution in any of these high risk intubation scenarios where you don't want to drop your SVR too much, your systemic vascular resistance. So, I would add, if your blood pressure is in a good place, giving propofol for sedation or for intubation in the case of asthma, for example, can bring you some extra help in terms of some bronchodilation. I would otherwise avoid its use, certainly if your hemodynamics are a struggle. Intratracheal Ventolin in the case of intubation, we can nebulize that, yes, as Katie is saying as well. And I think at that point where you're invoking intubation for asthma, these are typically patients that are getting significant IV bronchodilatory therapies, and so it may become less relevant, but would certainly support continuing some degree of tracheal delivery in that case. And Jordan's asking about co-infections. So it's a good question, and of course we have to practice stewardship with antibiotics, just with the sheer volume of children that are presenting. I think I would have, in the current climate, a lower threshold to act on X-rays, where there may be something focal, and I say that just because, again, we've had any number of viruses, whether it's paraflu, influenza, where there's been growth from blood or from bronchoalveolar lavage in the case of children who are intubated with Staph aureus, with strep pneumo, not resistant. Like the strep that we're seeing is sensitive to our usual therapies. It doesn't typically seem to need vancomycin. We're not saying MRSA, but I think I would advise that if you are escalating support, and like Jordan is saying, needing to place someone on high flow and perhaps unable to move them off that for longer than you expect, would have a low threshold to start that. And Tejpreet's asking about medication of choice for intubation for asthma. And again, my more important choice is I really, don't intubate asthmatics unless it's an absolutely extreme situation. But depending on your hemodynamics at the time, would favor a high dose of ketamine and fentanyl and then rock, right? So that would be my choice. If you feel safe giving succinylcholine, the faster you can move those patients into a place where they can breathe for themselves and exhale for themselves, the better. So, but rock doesn't stay in your system so long that's such a problem. And Heather asking about continuous Ventolin nebs versus IV Ventolin. So yeah, always sometimes it's a style choice. I think for me personally, I start with continuous Ventolin nebs. I add IV Ventolin if that isn't doing enough. If I am escalating IV Ventolin beyond 10 micrograms per kilo per minute, at that point, I can probably stop the continuous nebs because it's arguably not doing nearly as much as what you're providing IV. I don't know, Heather, to be honest, like what the preference might be in an adult ICU. And I think that IV Ventolin is not used as frequently in the adult setting from my limited experience in that context. So I would favor continuous nebulizations so long as that seems to be working. You might have, your pediatric perspective might be that you could remind, your adult colleagues in that context that, we do use IV Ventolin and have reasonable success with that. But that's also, if they have questions about that further, you can certainly direct them to us as well. They're supposed to be able to reach us at any time through Critical too, and hopefully that can happen as needed.
Yeah. Could I just add to that also, just in terms of IV versus continuous? Often we're doing continuous nebulizations when they're on a respiratory support is when we're typically starting that. So they're already high flow or non-invasive. And so it depends on your system, but sometimes the deposition of the inhaled meds isn't as great through some devices, in particular non-invasive, if you have quite a few leaks in it. So I would generally say, you're right, we start out with continuous nebulized, and then if that's not enough response, then we would move to IV.
Yeah, no, exactly, Katie. And yeah, but now I agree, like succinylcholine will give you, it's a shorter half-life for sure. And it may get you quicker to a place where your patient might be breathing spontaneously, which can help. But I can't emphasize enough that the number of times in a year that we have a child intubated for asthma is, like, I don't know, Katie, maybe every 2 years or something like this. Like it should be an extremely rare phenomenon. And I can't emphasize enough that if you feel like that's in the cards, like do reach out to us early and often. And one thing that I think we've found a lot of success with is that BiPAP, goes a long way in avoiding intubation in these patients, because it supports their work of breathing, often, well enough to allow these therapies to come into effect and move beyond a point where intubation is necessary. So. I'll go through this really quickly, Katie, and then let you take over here. So this is just to, we've talked a bit about these three kind of prominent presentations that we're seeing these days. When looking at using non-invasive ventilation in children, I just want to talk about some of the risks, contraindications, and challenges we see in that context. So the risks include, pneumothorax, pneumomediastinum, agitation, aspiration, and some hemodynamic instability, right? So you're in terms of air leak, it's something that you of course you can't predict. It's just a risk that you have to accept, that by virtue of delivering a degree of positive pressure, especially in pathophysiology where there's air trapping, whether that's bronchiolitis or asthma, there's always going to be some risk that there'll be a bit more air trapping with the positive pressure you're delivering, such that you may provoke, an air leak. Agitation, it's uncomfortable to have these masks on, and for the younger children who don't understand, why they have a mask on their face, especially if they're already again wired on Ventolin, or just mad about being in hospital or upset about all the strangers around them, this can be a very agitating device to place on. And for anyone who needs a full face mask, there's an important aspiration risk. It'd be a risk regardless, but there's air that can go into your upper, gastric tract and provoke vomiting in and of itself. And Ventolin can provoke vomiting, but when there's vomiting and you have a full face mask on that's driving a degree of positive pressure, there's always that risk that some of that emesis can be aspirated and make a bad situation a bit worse. And then hemodynamic instability just points to the impact of again potentially increasing intrathoracic pressure. Bear in mind though that compared to moving to strictly positive pressure ventilation, like when you sedate and muscle relax and intubate a patient, with positive pressure as an adjunct, and that patient is still generating good negative pressure breaths. So it's not to the same extent that you'd expect a hemodynamic effect from this device. With longer usage, we talk about other things, but this shouldn't be something we're talking about in the context of emergency stabilization. Contraindication. So air leak is not an absolute contraindication. We've placed children with, small pneumothorax or a pneumomediastinum on non-invasive, again, because it's a degree of positive pressure that isn't as severe as if you were to paralyze and ventilate that patient. So sometimes we accept that risk and just monitor closely for signs of worsening, or preemptively sometimes placing a drain. Recent upper airway surgery, this is a very rare contraindication in the context we're discussing, because that's typically only the case for the immediate post-op period, and those patients should be in hospital and not presenting to community emergency departments. And then using in caution when there's a degree of obtundation, just because, again, that can exacerbate the risk of aspiration if there's any emesis, et cetera. But you don't have to have a child with a perfect GCS to place them on non-invasive ventilation. And many children, with a degree of CO2 narcosis, for example, do extremely well on non-invasive ventilation. And it's just a consideration for children where you're worried about any loss of airway reflexes. Non-invasive ventilation does not constitute a protected airway, right? So it's something that can bring that aspiration risk to the fore. For management of agitation, we'll just say the key thing is this sort of judicious management, that there are important risks, as others have also, highlighted in the chat, in terms of hypotension in the context of children with asthma, children with ARDS, and they are sensitive to agents that lower SVR. So if you're trying to escalate their care into a non-invasive support, avoiding benzodiazepines would be great. Sometimes not possible. If you are compelled to give a benzodiazepine, would just give it in low doses, to very much underdose. It's easy to give more, hard to pull back, when you've given enough that's provoked some hypotension. We will often use dexmedetomidine, and this is something that our transport team will have with them and can start, when they retrieve the patient. And if you have it on hand in your center, and if you have or are interested in developing some familiarity with it, our starting dose is 0.5 micrograms per kilogram per hour. We like this drug because it does not compromise respirations, and it tends to make children much calmer and able to tolerate their non-invasive support. I will say, one important side effect of dexmedetomidine, given its alpha effects, is bradycardia. And so if you have a child, for example, I'm thinking of maybe those younger patients with bronchiolitis who have very prominent bradycardic spells whenever you're suctioning them, those I would avoid dexmedetomidine. But for older kids who need some BiPAP with asthma, this is something that can be helpful. And ketamine as a sedative can also be a helpful adjunct and a bonus, when you're trying to manage someone with a degree of bronchospasm. And again, just to err on the lower end of dosing if using benzodiazepines. We'll leave some of the troubleshooting to Katie. This is just to bring my part of this talk to an end, just to highlight that while we are looking for disposition of patients to perhaps be less transfers to sick kids, for patients that are appropriately managed in the community or managed at an alternative community site. And there are, of course, many patients coming through your door now who need acute care transport or, need to come to the ICU or the cardiac ICU. And, please activate critical, of course, for all of those cases as usual. And please let me know, and I put my email at the end here, if there's any concerns, ideas, feedback, if there's any cases that you feel have been complicated by delays in transport, especially a delay that we're not communicating to you, please do feed that back to us as well, so we can make our system better and more responsive to you. Remembering that we can always be reached after the initial critical through our ICU front desk at this number here, 813-6486. And remembering that, if this child does not need ICU but needs a PEDS bed, to make your life simpler and to make the bridge call more focused, be great if a disposition can be identified prior to that call. But remember, our philosophy in transport is patient first, bed second, and we're very happy to dispatch, whatever team is available. to any patient who needs that team, even if we don't know where they're ultimately going to go. And a real-time advice is certainly always something that we want to be able to offer. This is my email. There's a question from, I think, Abdulaziz.
Oh, yeah. Thank you very much for taking my question. I was wondering, you're talking about the ventilator infusion. As much as I'm aware, we cannot give the ventilator infusion in out of the ICU, like
Correct.
in the pediatric ward. Is that true?
Yeah, IV Ventolin would be something we only deliver in ICU. Yeah.
Okay, thank you.
And I think that's true for continuous Ventolin nebs as well, right? So any child, the Aerogen can deliver continuous nebs during that time, for example, when you're considering that these are back-to-backs. I'm doing like over an hour, I'm going to give this child 15 milligrams of Ventolin through their Aerogen or whatnot. That's fair to try acutely and to see that as a sort of set of back-to-backs or equivalent. But beyond that, we wouldn't, that's something we would expect to be managed in the ICU if you're needing more than that.
Yeah, I was just going to add, like, not to add to anyone's workload and new practices here, that the continuous salbutamol typically goes up to 20 milligrams, which is about 4 treatments an hour. So if you put a treatment in your Aerogen every 15 minutes or every 20 minutes, you'll be getting in the dose of what we typically give as a continuous salbutamol. And you could continue to do that before the patient is transferred out.
And I think Amenab had a question about the IV salbutamol dosing. So the maximum, like on the medication label, they say, for teenagers and older, you shouldn't give more than 20 micrograms per minute as a max dose. For children, we see it more as micrograms per kilo per minute, where we start at 1 mic per kilo per minute, or, and like Kevin's highlighted, there's practices elsewhere where you might start at an even higher dose. And we don't typically invoke a strict dose maximum for children. And I've certainly seen some that have been escalated even as high as, 10 plus, mics per kilo per minute. But that you tend to be dose limited by toxicity. And so it's, those children who are incredibly tachycardic and have a lactic acidosis and so forth, you'll see us turn that down. Electrolytes, Daniel, yes, I can't give you a frequency per se. Very important, as you mentioned, to pay close attention to potassium when you're starting to run, even, of course, continuous Ventolin nebs or frequent sets of back-to-backs would favor, making sure they're on 40 of K in their IV line, in addition to D5 normal. But we generally don't get into significant hypokalemia unless we're running very high doses of IV Ventolin. So for your purposes, in the community setting, I think you shouldn't need to be checking more than every 6 to 8 hours at most. And ultimately, patients you're admitting shouldn't be needing Ventolin more than every hour. And so again, I think you're not going to need such frequent electrolyte checks. And Renee, sorry, therapies for bronchiolitis. We're for those who are coming to ICU, where we're really trying to troubleshoot, a continued degree of respiratory distress, maybe trying to avoid intubation, we'll use, nebulized Ventolin again in those cases. If we're seeing success with Ventolin, we might start steroids, but not often. I think fundamentally what we're generally doing for our children with bronchiolitis is, apart from more respiratory support, it's the same supportive care that you're delivering. So I find, and Katie, I'm sure you see the same, like it's variable, but for the most part, there's no consistent use of Ventolin or hypertonic saline or steroids. It's really kind of intermittent use depending on what exactly we're hearing at that moment. But the exam tends to be so dynamic that there's no set of things that we'll do for all patients. And Peter, yeah, which CO2, again, it's going to depend on the context, right? Like, really, and what you've tried, so, we'll have asthmatics who might come in with CO2s of 60 or 70, but who respond well to therapy and are normal after a few hours. So I can't give you a number per se. I think really just call with any patient that you're considering, look, high flow isn't cutting it, I need to escalate to non-invasive and I need support, or I have an asthmatic patient who's, in spite of escalating these therapies, is getting into more trouble or is still in the same trouble that they came in with, and these are patients that we're should be quick to send our team out to you. Hand up from Jasvinder, and then I think after this we'll have to move to Katie's talk.
Yeah, so role of racemic epi in bronchiolitis. Are you guys, I know a couple of years ago the people were using it. Are you guys still recommending that or no?
We aren't using that. And Katie, unless you've seen that used recently, I've seen occasional Ventolin use for those rare kids who seem to respond to it. I mean, they're all wheezing, but even with Ventolin, like we're not consistently seeing a response, of course. So I would say at most we're using Ventolin, sometimes some 3% saline, like hypertonic saline, to help mobilize secretions. And if patients are very consistently responding to Ventolin, we might start steroids, but we aren't using epinephrine in our setting here. And Manal's asking about dilution of Ventolin. This is for the Aerogen device, Manal, or for the when you're delivering nebs?
It's actually when we give infusion.
Like IV Ventolin infusion.
Yeah, we have a lot of confusion among our emerge nursing staff, and it takes 3 hours for them to figure it out, along with calling pharmacist on call, because of course these cases present after hours.
Yes, of course. I don't have a guide to that offhand, and I can see if I can find something though. But again, like,
thank you.
Our transport team can also bring that with them and get that started too. So hopefully that's something that, if you feel a patient's heading that way and we discuss that on the call, we can make sure to have it ready to start too. I want to give Katie time to speak to her slides too. So should we move forward? Katie, do you want to, I'll stop sharing my screen and then.
Sure, yeah.
Okay, sorry, I haven't left you too much time, sorry.
No, that's okay. I will try to run through things quickly. Let's see if you guys can see this. Is that, I'll get it into full screen mode here. Is that working for you guys?
Yep.
See that, Andrew? Okay. So I've actually used some of these slides for some previous talks. I've actually focused more on respiratory therapists in the community. So you may see some repeat if you joined one of those, or vice versa if there's an RT on this that's joining this webinar. But really what we are trying to focus on is just some of the basics about equipment, some of the challenges specifically we've had with NIV and doing this in pediatrics, and offer some general approach to some settings and the management of these patients while on these types of support. So I will just start with a kind of overview of a lot of different equipment can be used potentially with children that is also used with adults. So depending on your institution, you may have a variety of any one of these devices, if not other ones. And most of the time, it's just really important to know what you have and what the options are for them. And some devices in particular, for example, this third one here is known as the T1 ventilator, or a transport ventilator. So this can do both invasive and non-invasive and pediatrics and adults, but does have different valves and circuit configurations depending on which population you are managing. And so some devices span the whole width without any changes to it. Some devices have weight ranges, though certainly you can talk around. Sometimes we have stretched the weight restrictions on some of these devices to do different things. And so the bottom line really is just encourage with, I encourage you to really work with your RT team to know what you have, and either the clinical support specialist for the devices that you have in your organization, because each one is unique in terms of the changes you may need to make to be compatible with pediatrics. And so really what I would focus on specifically if you're using this not frequently is make sure you have some sort of reference for your staff, whether it's through pictures or set up or have something that's accessible for your staff to really reduce the cognitive load and make it straightforward for them when they have to initiate these therapies for patients that are outside of their normal comfort zone. And so, for example, for the Trilogy, there's a lot of overlap whether you can use the adult circuit actually down to 3 kilos or the adult mode. But if you use the adult mode, you then have to use a flow sensor, which has 9 mils of dead space. And so we didn't really like this. There might be some stuff related to your equipment that you may want to figure out. And so we just used a 10 kilo cutoff to use a smaller neonatal sort of setup and a greater than 10 kilo for the rest of the children that we see when we use this device. In terms of non-invasive, we have both single and dual limbs for non-invasive, and any of our acute care ventilators are usually a dual limb system. And so when you're using a single limb non-invasive system, you usually want an interface that has a leak. And this comes into play when you talk about devices and whatnot. When you use a dual limb, typically your interface for non-invasive will not have a leak. And this comes into play in how we address some of the management on non-invasive later in terms of synchrony. So in terms of the one major challenge we always have in pediatrics, and we have no golden answer for this, but is the interface. And so a lot of you may be very familiar with the flexi trunk if you work in a neonatal area as well. And so this can typically get up from a 4 to 5 kilo kid. Once you get to 6 or 7, you might be able to make this device work for that age range, but usually at that point, you'll start to struggle with getting effective therapy through this interface and making it fit properly. One thing that's rather forgiving that we've really adopted heavily in our practice is the total face mask for acute non-invasive. So this is an interface that actually goes all the way over the mouth and nose, and the whole face, maybe for the forehead, and it just allows you to fit the patient a little easier. It works quite well in terms of minimizing the amount of leak through some of the interfaces. And so this is an option that we often use when they're coming to the ICU to initiate non-invasive. There are nasal masks, and you can certainly start there if that's your comfort zone. And all of these typically either come in non-leaking or leaking interfaces to go with the machines that you have. Once you get to, probably 8 or 9 years old, you can probably start using those adult full face masks that you would use for any adult that comes through your emerge for non-invasive. The extra small size in that usually can manage for those patients. The one thing we don't recommend is trying to use a nasal mask for an adult as a full face mask for kids. One of the reasons is basically it just doesn't have an anti-suffocation valve and is really not designed for that. So we wouldn't recommend it. And the headgear will be a disaster because it will be way too big. So I've just put this as an example. Sorry, I'm going to get us a bit smaller so I can see the whole screen. So for a 5 kilo patient that we have to use non-invasive, they may only have a tidal volume or a size of breath that's about 30 mils. And a lot of these devices have a reasonable amount of leak in them, even if you try your best. So a single limb circuit usually displays a leak in terms of a liter number, whereas the non-invasive dual limbs usually display the leak as a percentage. And so a lot of people will see a leak on the dual limb that's 80 to 90%, and that makes them concerned because it looks like a really large leak, and they may try to address that. And similarly on these single limbs, it may be hard for the ventilator to actually sense the patient's effort to give them a synchronized bi-level support for non-invasive. So what we really do to address that, so I'm just going to try to get over here, is we basically remove for the single limb that extra exhalation leak, recognizing that the leak that we have has enough leak in it on the mask to provide a safe system for the patient. We then also pay very much less attention to what the values on the ventilator for non-invasive are showing us. So we look at our non-invasive ventilator to make sure it's synchronizing well, but we don't necessarily pay attention to the tidal volumes or the minute ventilation or any of the numbers on it. We really look at the patient for work of breathing and tolerance for that. And then the final thing we might do is if you are only using a nasal mask, we would consider moving to something that would minimize the leak if they are leaking a lot through the mouth. But ultimately, you should really look at your patient do they look comfortable? And if they look comfortable, then you're probably good enough until transfer. I do also make sure that your RTs have set some alarms on the device too. Andrew's already mentioned that compliance and tolerance can be tough, and you can imagine if this is coming to your face as a 3-year-old, they don't have a lot of understanding of what exactly is going on. So, you know, there is certainly some nursing and supportive cares with the parents that you can use. One strategy we sometimes use is just get the mask on at a relatively low pressure on the non-invasive and then work your way up to what is supportive. And one thing we ask often our nursing colleagues to do is make sure that an NG or an OG is inserted to make sure that any gas trapping or any gas that is going into the stomach can be vented. And so that's one of the things our nurses often do before we start to even put on the mask. And as a final point in terms of all of this, given you can have a lot of these challenges and depending on your interface situation right now, you might ask yourself, is high flow adequate? And so when I think about maximizing high flow, I've put our initiation pathway here. So we certainly initiate at 2 per kilo for those less than 10 kilos. And then those age or those weight ranges beyond 10 kilos, we use kind of a more broad category. And so after they go on, typically we expect that they have a good, if they are going to have a response that's to high flow, we expect it to happen relatively quickly. You know, usually you see improvements, I would say in 10 or 15 minutes if they look well on our inpatient wards. We do kind of more a formal assessment at 1 hour. And we look at whether they're requiring less than 60% as a hard cutoff. But that doesn't mean based on that, we do and fall into a different pathway. So that's just our standard for when we would engage a larger team in terms of the conversations we have on high flow. These conversations can include like a more full assessment, looking at chest x-rays, potentially looking at blood gases to do a bit more of a in-depth review of the patient. You know, depending on what their situation is, there might be diuretics, there might be, if they're incredibly wheezy, this might be when we would start to invoke using a Ventolin for bronchiolitis or something to try to see if we can optimize them and avoid having to escalate further. I've also put, there is a big trial called the Paris 2 trial, and they have different flow rate ranges than what we have on our policy. So I just put it as an alternative that is totally reasonable and within the norm. And depending on what your situation is, you may have to, if you don't have anything and they look really unwell at 2 liters per kilo, you may try a little bit more flow just to assess tolerance and patient comfort. But generally, I would say, if you have to use quite a bit more, it's probably that you need to escalate your support. Andrew, I don't know if is that reasonable to say? Yeah. One thing I have put is the high flow nasal prong sizing and flow rate guide. So there's lots of different pediatric sizes for the prongs. The ones you're probably most used to is probably the purple green ones that are used for those kind of, I'd say, term babies to slightly larger toddlers. If you have a slightly larger kid and to get to the therapeutic flow rates that you want, there is an extra large pediatric prong that actually is used on the Airvo in the adult mode, but has a different or it allows you to certainly go much higher on your flows. They often, depending on the device, but they often say have a 50% prong gap in your nares for high flow nasal cannula. And then they show these pictures for a 50% gap. So really what I kind of focus on is there at least a little bit of a gap around there? Because this certainly doesn't look like a 50% gap in your prongs. And likewise, this is another picture. It looks like the prong occupies quite a bit, but you just want to make sure that there is some leak around the prongs to allow for exhalation. And then certainly for the older children, we will go into the adult sizes for the OptiFlow prongs. We use the Fisher-Paykel system at Sick Kids for our high flow nasal cannula. And so just be mindful when you're choosing your high flow nasal cannula that you don't undersize the prongs and then get limited by how much flow rate you can provide to them to support the patient. In terms of choosing NIV settings, a lot of people have asked for algorithms. We don't necessarily have any, but when I think about what we do in our unit, we generally will use, I would say, more commonly bi-level by the time they get to our unit, but there's certainly situations when we favor CPAP. And so certainly the smaller kids where you are going to have more leak and more challenges with trying to get 2 levels of support in any sort of synchronous fashion, we sometimes do start those patients on just straight CPAP. Likewise, if you think you want to do bi-level, but you're just running into a lot of problems, it's a good default to come back to still some positive pressure and provide at least one level of support, especially if you're exclusively having oxygenation challenges or have a clear spot you want to improve with positive pressure, but they don't have hypercapnia, then we might consider CPAP for those. And depending on the device, you may be limited by that. Or if you have a really small infant and apnea is the primary concern, then CPAP certainly is a go-to standard for that. Bi-level, we certainly use more often in our older children and adolescents because they can trigger well. We certainly use this specifically in anyone presenting with neuromuscular disease and hypercapnia. We would choose a bi-level support just to augment almost that inspiratory effort for them to make sure that they are getting better non-invasive support. And if they present with a lot of distress or worker breathing, then that would be our favored mode. And depending on your device, your bi-level support or your 2 levels can be called lots of different things. It can be called ST, NIV, NIV PC, or NIV pressure support. One thing we don't use a lot in our unit, but if it's your only option, it can be considered is an asynchronous bi-level. So depending a lot of neonatal devices through the flexi trunk, if they're doing 2 levels, it's not actually looking to sense the patient and coordinate with their efforts, but just rather provides those 2 levels of support. So we don't have a lot of experience in our unit, but it might be something you have to try. And then always on the other end of CPAP, there is a bit of overlap of certainly if you've maximized your high flow, there might be some patients that, you know, depending on where you land, you might just need to use high flow nasal cannula. And so I don't have a full algorithm for what we do, but I tried to put it down on paper in some sort of fashion that makes sense. So I do have a little bit of a bundle that I would for sure think about before we go on to high flow for the team. So you know, making sure you've maximized your other medical therapy. Have you started the consultations to Critical Ontario? Have you made sure that anyone who needs orders for what they're doing, that is addressed? And then in terms of starting, are you making sure that the patient is on full monitoring for the initiation? The family and team is aware of what the plan is and the next plan should it fail? And have you gathered all the equipment to make sure that you know that you can do your therapy correctly? And so from there, we would initiate NIV most of the time. In our organization, it's in the ICU. We'll hold them on high flow nasal cannula on the wards. But you know, if we need to start anywhere, we move ICU to where it needs to go before they come down to our unit. If you're starting with CPAP, people always ask, like, what do we start at? I would say 5 to 8 is a good starting point for anyone with a reasonable amount of distress. And you just need a bit of single level support. In terms of bi-level, depending on your device, you might have to set rates or I times, but certainly 10 on 5 as a starting, and then augmenting, you know, you could go up as high as, you know, 14, 16, 18 on that. I can correct the slide, it only says 14, but, and your EPAP, again, just like the CPAP, that's your baseline level. We would start that at 5 and augment somewhere to around 8, maybe even 10 if you're really pushing it for an adolescent. If you need to use more than, I would say 10 of CPAP, or sorry, these are my, now I know why I'm looking at these numbers and saying they're really low. These are kind of the starting settings that I would start with. And then if you optimize your NIV, you would augment from there, usually by 1 or 2. If you need more than 10 of CPAP, then you would probably look to transition to non-invasive or bi-level to give a bit more support. And then you're always going to be assessing your response through your regular assessment. You know, if there is a decent response or they stabilize, then I would say we would continue that support until transfer. If they don't have a response, then there's further consultation with either Critical or the broader team for what is the next escalation. And always off the side of this, you know, if they stand up in bed when you try to put the non-invasive mask on and it's going to be too tough to get them to wear it, then we might just leave them on high flow until we get a better situation for it. I'm just looking at that time. So if you have to keep anyone on, one common misconception is tighter masks is a better situation. And so I know Andrew mentioned this, but just if you have to hold on for anyone a little longer than you need would normally need to before transfer, we would probably recommend at least every hour, at least an assessment that the mask is in a good position and reasonably positioned. And then usually every 4 hours, we actually take the patient off to look. And so this is an example of a mask that was put on too tight, what you would see. And certainly any humidity for these devices is important if you're on it for any prolonged period of time.
Katie,
Yeah.
just a couple of questions relevant to what you've just discussed. One from Sarah, just asking about securing NG tubes, worrying about a leak, when you have an NG. I think our practice tends to be NG rather than OG tubes.
Yeah.
And I think with our mask interfaces, we don't tend to really get a leak with those. Is that right? Or
Yeah, so I would say our flexi trunk use is a lot less in our PICU than in a NICU. So there are a lot of NICUs that practice if they're on that nasal interface alone, then they typically go with an OG to avoid leak. If that's the practice and you have someone of that size, you could continue with that practice. Often when we go to the total face mask or the nasal mask, we do go to an NG, and these usually seal adequately enough around that, that it doesn't cause a significant amount of leak. Yeah, that would be how the difference between whether you're using maybe that small neonatal interface versus a larger kind of pediatric interface.
And Darlene was just asking about when you mentioned the suggested upper pressures, I think on the last slide, were you discussing absolute pressure, like the IPAP or the delta?
So those were I apologize because I should have looked at these a little closer. Those are our starting pressures of 10 to 14 for an IPAP, I would say. Upwards, we typically go up as high as, once you've an IPAP of probably 20, if you need more than an IPAP of 20, meaning a PIP of 20, you usually struggle with more leak around the interface at that level. So yeah, a peak pressure of around 20. There are certainly some, I would say, SMA patients with a perfectly fitting mask or whatnot that may use 22 or 24, but that would be the exception. And certainly in acute non-invasive, if you have to go above those with a reasonable amount of EPAP, then you probably maxed out that therapy. Okay, so I'm just going to quickly run through, and I know we're tight for time. So in terms of setting a ventilator, I just would add that there are only two ways to really inflate the lungs, and that's with pressure or volume. And so what I would say is your RTs within your organization are very familiar with mechanical ventilation in the intensive care unit for adults. And so they'll be a great resource with you in terms of what is going on. And so if you want to know more, I would talk through with your RT about your settings. And I kind of put 4 questions that I think are important things to look at. So first, are you able to achieve adequate tidal volumes for your patient? And usually somewhere on your ventilator, you'll see VT or VTI and VTE. That's an inspiratory and expiratory tidal volume. And that's usually achieved by using either pressure. So on this ventilator screen, I have set a mode called pressure control. And this is what provides the pressure to give you your tidal volumes. Alternatively, you can set a volume, and then you'll look at your pressures a little bit more. The second question I would ask is ventilation okay? And I specifically use okay because we don't target always normal gases for a lot of our patients. And this is really achieved through your respiratory rate and that tidal volume that you've set. So the combination of both of these things is what's going to achieve your ventilation. The next question I would ask is your peak pressure below 28? And this is part of the lung protective strategy we often use in mechanical ventilation. And that is usually achieved by looking at the top number on your ventilator. It's usually called P-peak or PIP. And the final question I would ask or engage is really, are you having any challenges with oxygenation? And so there are some common ventilation settings that we've provided in some of our other talks related specifically to the RTs. Generally, what we do is we target a tidal volume of 6 to 8 mils per kilo, and we move to 4 to 6 mils per kilo. So going smaller to be a little bit more gentler on the lungs if we need to go to an ARDS lung protective strategy. And so what does that mean in terms of some of the settings? So your pressure control typically shouldn't be much above 16 or 18, and we're looking for a P-plat less than 28. The two settings that get adjusted for size or age would be your respiratory rate and your I time. And so I've put a little chart here with some broad ranges on here where your RTs can help you assess whether they're set appropriately. And the one other thing, just for context, depending on what your organization uses already in the ICU for max PEEP range, we would typically say that the upper PEEP level for a lot of patients will probably basically starts to go down with age. So your adolescent, you could certainly treat like an adult. And so maybe you will get up to a PEEP of 20. Certainly within our organization, we often don't use quite that high. And then as you go down in age, you'll see the max PEEP level you may need to set will probably be lower to achieve max best recruitment for these patients. And these aren't, these are ranges, what we think, 90% of the patients fall in. Certainly there might be some assessments and unique cases where you might fall outside of these ranges. In terms of mode selection, just so you know, we use a lot of SIMV PCPS at our institution. That's really kind of a cultural thing, and it's not necessarily needed. And just for context, for a lot of your RTs you may be working with, they may be more used to using a full control mode and only pressure support. So if that's the case, then I would recommend just using the mode that's most familiar to people around you to reduce the cognitive load of how they have to think about things and how they manage the patients. We sometimes use specific modes for different pathophysiology. So certainly any time you're trying to strictly control the CO2, we typically go with a volume targeted mode. Asthma, we typically go volume targeted, knowing their pressures are going to be really high. If you happen to intubate and have a really large leak, then we would pressure ventilate those patients. And if they're awake and really tolerating everything well, then pressure support ventilation, though I suspect you guys will probably be keeping them sedated before transfer out. So I ran through a case, or I put up a case. I know we have 5 minutes left, so I'm just going to kind of quickly run through this. So let's just say you have a bronchiolitis patient who presents to emerge. You tried high flow, you maxed that out. They looked really poor. They were in respiratory failure, having apneas, and they were requiring 80% and really looked unwell. So you proceeded to intubate them with a 3.5 ETT. They're very well sedated post intubation, and that's the first time you get a gas or an ISTAT through your emerge RNs, and this is the first gas that you see. Your SATs are currently 98 and end tidal is 54. And so I'll give you a few seconds to think about these things, but are you able to achieve adequate tidal volumes? And so, I think about, oh, it's right up here. It's on the top of the slides too. 5 kilos. So you're getting about 4 mils per kilo. Is the ventilation okay? You have a acidotic gas, not a lot of compensation happening at this phase. Is the peak pressure below 28? So are you being reasonably safe? It's right now only 19. And are you having any challenges with oxygenation? Right now you have a peak of 45 and 45%, and your SATs are 98. So in this situation, if I was the RT there, I would probably say, you're doing okay, but you're not optimized. So I'd probably go up on the rate. Given they're not breathing, that will help to increase their minute volume. The tidal volume is on the low end, so you could go up on that. The blood gas is not ideal, but it's also not the worst in terms of a CO2 of 62. So hopefully those two changes can address that and certainly have reasonable oxygenation on these things. So I would say hang tight there, and we'll continue as we go on. Or as they we'll continue with the ventilation optimization when they get to sick kids. And so one thing I know you might be helping with any adolescent consults in terms of NIV and mechanical ventilation. And growth charts won't be abnormal to you, but might be abnormal to some people who work in adult ICUs. And just remembering that your 14-year-old is almost the size of a regular adult. And so sometimes that's a supportive tool that I've used actually to help reassure patients the size of the patients they'll see in terms of adolescence. And so in summary, use the equipment you're familiar with. There are some challenges in terms of size and equipment and doing bi-level support in terms of synchrony and getting them compliance with using BiPAP in children. And so keep that in mind. We use both CPAP and bi-level for non-invasive, and critical and your RTs will be able to help you with any mechanical ventilation. If you're looking for more support on ventilation, one really great tool that I've referred a lot of people to is there's actually a really good vent simulator on Open Pediatrics. And I just want to thank you for all the help, and thank you for inviting me to present today, because it's quite, it's a lot of, we're going through a lot. So it's really nice to have you. And here's a quick evaluation.
Thanks, Katie. That was very comprehensive, and I think, really laid out a few important, points in troubleshooting, initiation of this sort of support. And I think, unfortunately, we're pretty much at time. I don't know if there's any last questions anyone want to throw in the chat, but please do fill out the eval if you have time. Please know that we know how busy it is out there in the community, and really, really grateful for the incredible amount of work that everyone is doing there. And hopefully, if anyone is really interested in more of this, critical care management, please reach out to myself, to Katie, but importantly, in the moment, please do not hesitate when in doubt to reach out through Critical for any advice and to get our team out there and so forth. And hopefully we'll be through the worst of this surge before too long.
Andrew and Catherine, I want to thank you on behalf of Connected Care, who's had the pleasure of running sessions this week for over 1,300 participants across the province, but you won tonight with over 265 participants. An amazing turnout tonight. I can't thank our medical colleagues who are spreading the word. We will continue to distribute the webinar series as they come forward, and we're working very hard to get the webinars up as well onto the Connected Care website. Please do visit the website to pull the information, and if you have thoughts about other topics that you want to hear about, also please share them through the Connected Care inquiries email that's located on the website, so that we can help building things out. And so much thanks to terrific colleagues for making this happen tonight.
I saw one question about titrating BiPAP. Yeah, there we go. So yeah. I would say, when you're starting, go up as you need to kind of get to where you think is the baseline. And then from there, I would start to kind of space out your changes. So, kind of have in mind what you think you want to get to. And I guess it depends on your approach. So you could get those on. If you're getting the device on at a lower then go as quick as the patient looks like they're tolerating to get to where you want. Yeah. There's a lot of things. I think I saw one more question in the chat, but I've.
Yeah, I think it was just for nebulization versus MDI.
Yeah.
And I would favor nebulization personally.
Yeah, we've moved in our ICU to almost exclusive aerogen use through our respiratory devices, because it is a really easy device to use, and it doesn't add any flow that kind of messes up with the flows through the respiratory devices that we're using. The other practical point, depending on the size of the circuit, so if you're on the small neonatal circuit, is there's no way to give MDIs through it. So you usually have to add a big spacer chamber or something to give the puffs effectively through the neonatal circuit. So sometimes we have used MDIs through the adult circuit, but I would say by default, we've almost moved exclusively to the aerogen. Yeah. Prior to escalating to high flow or NIV, how are you delivering Ventolin? So prior to escalating to those, usually I think our emerge pathway starts with MDIs for Ventolin administration. And then even our inpatient wards have a acute inpatient pathway with MDI administration of Ventolin. And it's only in the escalation phase that we would move to a nebulized liquid form.
And Katie, the highest flow that you use with the Aerogen when you're on the high flow nasal cannula?
The pragmatic question. No,
Lowest possible, right? Is the
yeah. So in terms of deposition with any sort of nebulizer through high flow nasal cannula, the best deposition of your med is at the lowest flows, or usually at low flows. I think they recommend 0.5 liters per kilo is some of the talks that the Aerogen have been giving. Some places we've adopted a 2-4-6 strategy for infants, children, adolescents for that, if they can tolerate their flows going down. It's a bit of a chicken and egg though. If you're on high flow because they need it and you can't turn their flow down, then we would give it at therapeutic flow rates and maybe just give extra doses, recognizing the deposition isn't great. And that's why we also would switch to IV salbutamol if we run into troubles in our ICU with that. Bronchiolitis typically don't get as low of a respiratory rate as an asthmatic. Usually our asthmatics are incredibly severe when we've intubated. So we certainly look at our auto PEEP and kind of balance the entire spectrum of giving them as much time to exhale while giving us a gas that is reasonably acceptable, but it's very acidotic usually. For a bronchiolitis, we would not necessarily always, we don't actually see a lot of auto PEEP automatically with that population. Yeah, so we would keep their rate typically 20 to 30 as a rough set of numbers.
Arif, yeah, RT to RT communication is a good question. I mean, importantly, you know, if there's a child who's, you know, moving on to non-invasive, for example, on the bridge, like what we'll often ask and are very happy to have, you know, your RT come to the line and can typically work with them, you know, through protocol to troubleshoot anything that's coming up. We also have, you know, we can always pull in our charge RT to join that conversation as well, for sure. For some collaborations, like for Sudbury, like some of the more remote centers where they might keep patients even intubated if it's a brief kind of stint, then we're also happy to use the bridge to connect RT to RT, but we're still kind of troubleshooting some of that communication there. And Amani is asking about high flow, you know, titration. The short answer is yes. You know, sometimes you know, the child's on 2 liters per kilo and they look incredibly well, and you just take it off, and you know, maybe they need a bit of low flow or whatnot. So really whatever they need. And you know, there's a ubiquitous use of high flow, of course, and I think it certainly can be a helpful way to maintain patients with bronchiolitis, for example. But you know, sometimes it's more than what they need, and that's fine to stop it if that's the case. Yasser's asking about eye time, Katie, for non-invasive, like for BiPAP.
Yeah, I was about to type it, but so we would typically, the shortest eye time we'd probably use on non-invasive is 0.5, and then going up to an adult would be 1.0. Or I always kind of speak about the range, thinking of your neonate and thinking of your adults, and pediatrics is going to fall anywhere in between. So if you have a toddler, they're probably going to be closer to that 0.5. There'd be 0.6, maybe 0.65. Usually you don't have great waveforms and analysis, so you're kind of just choosing a little bit of an eye time that, you know, hopefully looks synchronous with the patient. If you see the machine blowing and holding them there while the patient's taking 2 breaths, your eye time's probably too long. In terms of the stopping from high flow, there's a few strategies. I think it depends on what your current resource allocation for high flow is. If you only own a few devices, you may have a higher threshold. Our current bronchiolitis pathway recommends actually just weaning the oxygen down for bronchiolitis and turning the high flow off once they get off oxygen from the high flow. But we are also seeing a lot of high flow. So, we now just turn it off. And I think if they need a bit of low flow, half a liter or 1 liter, then we would switch them to that. In the ICU setting, we usually, if they're on 2 per kilo, we might do one, almost like a 1 strategy. If they tolerate 1 reduction, then off is another way you could approach it too, is do 1 quick reduction, see if they tolerate it for 30 minutes to an hour, and then directly off, as a kind of, condensing your weaning strategy rather than slowly incrementally going down. Yeah. Yeah. Yeah.
All right, I need to hop off to help with baby bedtime, but thanks again everyone for joining today, and we'll see you on the bridge, hopefully not too often.